Okay, so now we're going to look at some techniques, and we're going to briefly just talk about some of the physiology behind and some of the benefits of some other manual therapies. For the most part, as far as lab goes in class, I'm concerned about you being able to perform the massage techniques and the traction. These techniques and some of the stuff we're going to talk about are things I certainly want you to know, but we're going to cover more from a conceptual perspective. So the idea of myofascial release, so it's kind of a, myofascial release is kind of an umbrella term referring to any manipulation of muscle and fascia. So it doesn't necessarily refer to one technique. It's basically looking at anything that will take the muscle and the fascial coverings and basically manipulate it. And what you're looking to essentially have is a plastic deformation, or essentially create a, through the use of, your hands and whatever technique it is you're using, basically trying to create some type of permanent change long term in the tissue. So that's your goal with the plastic deformation. And there's kind of two subcategories of techniques. You have direct techniques, which work by essentially stretching the tissue. And then you have indirect techniques, which actually take stress off of the tissue. So some of the techniques will actually physically take the tissue and stretch it to manipulate it, whereas other techniques will kind of actually use movements and techniques that will actually take stress off of the tissue to kind of create a change in the resting tension of the soft tissue. And really, the bulk of where you'll learn a lot of this is through your continuing ed. So again, it's always important as clinicians to, look to expand your skill set. Certainly we'll go through some common things here and just some of the physiology behind how it works, but these will be some techniques that through continuing education you'll kind of expand your knowledge with a little bit more. Okay, so still looking at myofascial release. So again, the muscle just or the name just essentially comes from the two words, myo meaning muscle, fascia meaning the connective tissue. So obviously we know that, the muscle has both contractile and non-contractile components, and we can, manipulate obviously a lot of the different types of soft tissue. Activity and injury changes the length-tension relationship of the fascia and muscle. So essentially what happens through activity, even normal activity can possibly create some of these changes, but in particular when you have individuals who, do have an injury, or maybe they have some type of postural issue, can change the length-tension relationship of the muscles. And what essentially happens is you get an idea called what's called gamma gain, okay? So gamma gain is caused by increased gamma efferent neuron activity. So now what that basically means is, so remember the efferent, if you go back to your neuroscience, your efferent output deals with motor activity. So increased gamma efferent activity ends up increasing the tendency of things like trigger points and myofascial pain syndrome, because what's going to happen is the gamma efferent activity is going to increase tension in the muscle. That's going to create the different things like trigger points and tender points, and it's also going to increase input from the nociceptors, or the pain-sensing nerve fibers. And, common locations where this happens, the neck, upper back, and shoulder region is a very common area for this. Again, many times because of the tendency for people, particularly when they're, day to day sitting at computers and looking at their phones and what have you, starting to create a situation where those muscles have increased tension on them. And again, the physiology deals with, from the nervous system and changing that length tension relationship. And again, as I stated earlier, you have indirect and direct techniques. So your indirect techniques are going to be where you're actually looking to shorten the muscle, and by doing that, taking stress off of it and kind of quieting down that gamma efferent gain that I just talked about. Or you have the direct techniques where you're actually trying to get more of an actual manipulation and stretching of the soft tissue. Okay, so strain-counterstrain techniques, it has the concepts have some similarities to myofascial release in the sense that they do, much like myofascial release, they do look to halt inappropriate activity. The actual techniques that you apply are slightly different as far as what your focus is on. Also, like myofascial release, you do have two different types of strain-counterstrain techniques. You have direct and you have indirect. Direct is where you're actually going to apply a force against a restrictive barrier to improve motion. So you'll actually look to create tension and be able to improve a restrictive barrier by, being able to move once the force is applied to the area. With the indirect technique, you're actually looking to move the body away from the motion restricting barrier. So like myofascial release, there's direct and indirect techniques. Basically, what you're looking to do is with either one of these techniques, you want to be able to hold them for about 90 to 120 seconds and just make sure that you're slowly moving the body segment as you're doing this, because if you don't slowly move the body segment with any one of these techniques, you're going to end up kind of restarting that inappropriate proprioceptive activity and basically just, not allowing the treatment to do what you're looking to have it do. So myofascial versus strain-counterstrain. So we mentioned some similarities and differences between the two. As far as how you would apply them, you could have, again, differentiating between techniques. Myofascial release techniques tend to be better for more long-standing pain patterns, particularly those related to the spine, where strain-counterstrain looks to deal with more short duration pain patterns and is very good, particularly during tissue repair and during the early maturation phase. So these are typical time frames for when you would use these, but certainly, again, based upon your experience and what your knowledge of the techniques are, you can certainly look to apply them as needed. So joint mobilization. Joint mobilization is another manual technique. You could use joint mobilizations to both restore joint motion, ease pain, and improve willingness to move the joint. So basically, you essentially would either use it to either decrease pain or increase range of motion. And what you're going to utilize when you do this is you're looking to utilize the convex-concave rule, which we'll talk about in a bit. But basically what you're looking to restore are what are called the arthrokinematics of the joint. So the arthrokinematics at the joint are the movements that occur that we don't see. So what we see in everyday life are what are called osteokinematics. Those are our big movements, things like shoulder abduction, hip flexion, things like that. What we don't see is the rolling, sliding, and gliding that occurs inside the joint. So the joint surfaces have to obviously articulate and move. So what joint mobilization does is specifically kind of focus on being able to improve that aspect of movement in the case of restriction, and again, as far as a pain, it also has a pain relief mechanism. So for instance, a restriction of a posterior glide of the talus after injury. So many times individuals, particularly with ankle sprains, can lose dorsiflexion, and sometimes that could be just due to the actual joint capsule itself. So you would think, well, they lose dorsiflexion, let's stretch the gastroc and soleus to improve that. Well, if the restrictions at the joint, stretching the gastroc and the soleus is only going to do so much. So what we need to have happen is we need to restore that posterior glide to help improve the dorsiflexion, and you'll do that through a joint mobilization technique. So the biggest key point with joint mobilizations is understanding what's called the convex-concave rule. So if we're looking at this picture here, you have two different surfaces. So let's just pretend this is a joint, okay? And we have this surface here, okay? And we have this surface here. Now, what the convex-concave rule states is when the convex surface moves on the concave, the roll and slide go in the opposite direction. If the concave moves on the convex, the roll and slide, or glide as they're showing here, glide and slide is the same thing, they move in the same direction. So if you look here, in this case, if this is the surface that's moving, so this surface is stationary, this surface is moving, okay? The roll and glide are going to go in basically the opposite direction. The roll here, let's just say, let's say this is anterior over here, this is posterior over here, okay? We're having a posterior roll and it's gliding anteriorly, okay? Because this is your convex surface, okay? So always think a concave surface is like a cave, okay? So here's your convex surface. So if the convex is moving on the concave, the roll and slide go in opposite directions, okay? So the roll is going, in the case we're just referencing anterior, posterior. The roll is going posterior, the glide's going anterior. If the concave is moving on the convex, now they both go in the same direction. Again, if this is anterior, this is posterior, just for the sake of the picture. Your roll is going anterior. This is now your moving surface. The roll is going anterior and the glide is going anterior. The reason why you have to know that rule is because when you're looking at the different joints of the body, particularly if you're looking to improve range of motion, the only way you're going to improve the right range of motion is if you do the right mobilization based upon the actual bony surface that you're moving, okay? So if you understand that rule, as long as you know obviously know your anatomy and understand the joint surfaces, then pretty much your joint mobilization application should be fine. Okay, muscle energy techniques. This is just a technique where the patient will actively contract against the counterforce into a specific direction. What this will do is address the cause of pain, leads to pain relief, and reduces muscle tension and guarding. You commonly see a lot of muscle energy getting done. Very common to see with the SI joint, with SI joint problems, low back. I mean, it can be done anywhere. But basically, what this technique is going to use is an active contraction of a body part to basically kind of, either reduce muscle tension and guarding, or in the case of even like the SI joint, possibly looking to actually change if you have a situation where you have, either iliosacral or SI joint dysfunction, you actually use muscle contraction to kind of correct the dysfunction in that region. So this just uses that active contraction against the counterforce. So basically you would apply resistance, the patient would apply a force against that and use that muscular tension to basically correct whatever issue it is you're dealing with. Now, if we just look at the effectiveness of joint mobilizations, myofascial release, and just other different types of manual therapies, so most studies involve grade 4 manipulative procedures. So what that basically means, we don't do manipulations. We look to basically perform lower grade procedures. So, most of the studies you're going to find are going to be on those grade 5. So it does make some things difficult. However, we have discovered some things. For instance, earlier posterior mobilization of the talus could speed recovery and prevent loss of motion after a lateral ankle sprain. So you might actually improve if you manipulate and basically get that posterior mobilization, because what that does is it quickly restores dorsiflexion, which is one of the things that tends to get lost with a lateral ankle sprain. That posterior mobilization is actually going to allow for a faster recovery from that. We've also found that in studies that myofascial release can lead to improvements in patients with carpal tunnel syndrome. So there's some good evidence out there on the effectiveness of manual therapies. Plus, just as we talked about with massage and everything else, there's also the component to it, and there's value in this that, again, the interaction between the patient and the clinician, and just how that can actually also help, particularly as it comes to pain and just how the patient feels in regards to their actual treatment. Okay, still looking at the effectiveness of myofascial release and massage. Again, few clinical trials exist on massage. They do recommend massage for the treatment of low back pain. And again, they have found effective treatments with carpal tunnel and knee osteoarthritis. So there is some evidence out there on those particular conditions. There's probably some other studies even done recently on some stuff. here's the other thing with most of these techniques. They're low cost and they're low risk. I mean, for the most part, you don't really need any type of big special expensive equipment to do it because you're using your hands, and they're low risk. For most of these techniques, there's not a ton of contraindications. There's not a lot of negative things that could really happen, and there's not a whole lot of patients who get excluded because of that. So certainly, I personally feel that in sports medicine, we have to be able to use our hands in treatment, and there's a lot of benefit to that from the patient perspective, from a pain and functional standpoint. Okay, intermittent compression. So this is another type. This is more of a mechanical therapy. We're not using our hands with this, so this kind of gets us back out of the manual therapy. But what intermittent compression is going to look to do is reduce edema and swelling. So what we're actually going to be doing here is utilizing a mechanical device to actually promote the reduction of edema. And for most of the evidence points to this, is that this is the best treatment really from swelling and wounds from venous insufficiency. So it may not necessarily, there's not a whole lot of big support for treatment after musculoskeletal injuries. It's certainly something that you can utilize if you want, but it's one of the more less effective than some of your other modalities. And really, as far as a lot of times reducing swelling, active exercise is going to be better for that, because you're going to actually get the active muscle pump that allows the lymphatic system to reduce swelling in the area. So, really most of the benefits for intermittent compression, particularly if it doesn't use cold as well, there are some intermittent compression devices that will actually pump cold water through, so you at least get the benefit from cold. But the other intermittent compression devices just basically are pneumatic. They use air. So you sometimes wondered, is it better to just, either have the person do active exercise and, reduce swelling from that perspective versus utilizing a more passive means. So in the picture you see here, this is an intermittent compression device, and this is one that just is going to use air. So essentially what this does is it intermittently puts air into this, blows it up, puts compression, and then releases the air. So it's just like it says, it's intermittent compression. Now, there are intermittent compression devices that actually utilize cold water with it. So you'll actually fill up the unit. If this was a cold water compression, you'd fill up a unit with ice and water, and what it would do is periodically put it in and then take it out. So those machines seem to have a little bit more support in the research as far as musculoskeletal injury is concerned. So the compression stocking here is applied, and what you do is you basically, and you do this with either one, whether it's a cryo intermittent compression or just a regular air intermittent compression, you just adjust the duty cycle and the maximum pressure. So there's limited evidence as far as what's the most effective duty cycle. What they just recommend is 30 to 40 seconds on with 20 to 30 seconds off. Okay, that's usually pretty well tolerated as far as the actual compression device is concerned. So I'll just talk about intermittent compression differently. A lot of the other manual techniques that we talked about, they kind of have the same contraindications that we discussed with massage. Intermittent compression does have some different ones in there because of essentially what it does and its impact on the circulation. So, your contraindications here: healing fractures, gross joint instability, infection, thrombophlebitis, pulmonary edema, and congestive heart failure. So because of the fact you're putting compression, that's going to impact the circulation. You want to make sure that there's, none of those issues are a problem. The considerations for it, again, it's somewhat time consuming because you have to set it up. And I think probably the two bigger reasons, not even so much, if something works really well, then, certainly it could take the time to set it up. But the two bigger things is that the fact that the patient's not actively engaged, they're just kind of sitting there having this, device basically kind of trying to remove the swelling for them. And we know that pain-free active exercise is a better way to assist lymphatic drainage because active muscular contraction is going to be the best way to do it. and having this, device basically trying to supplement that isn't going to be quite as effective. So we'll talk about the effectiveness of traction, intermittent compression, because they both use, mechanical means of doing it. Obviously, we also know you can do, you can obviously also do manual traction as well, which we will talk about and we'll get the chance to do and perform in class. Traction, high versus low dose, both of them can help to reduce cervical spine pain and radicular symptoms. So think about those, the parameters that I gave you earlier on in the earlier parts of the lecture, as far as, whatever the diagnosis for the cervical spine pain is, you can manipulate based upon positioning, and, particularly when you're looking at intermittent traction, how long to hold the actual traction force on for. Again, intermittent compression, when you're looking at it compared to some other things, again, you can certainly decrease some lower limb and hand edema with it, and a fusion after an ankle sprain, but again, you're going to get your better results from active exercise. And I would say if your intermittent compression unit is going to utilize cold as well, at least then you will get benefits from the cold that you're using. So that could be a different thing as well. Again, there's just some lack of evidence for the treatment efficacy for musculoskeletal conditions as it relates to the intermittent compression. Again, for venous insufficiency, it works very well, but for your musculoskeletal conditions, we're not quite sure if it's better than certain other modalities that you can utilize. So in summary, again, use sound judgment. Again, your manual therapies, and these are going to be something that you're going to have to perfect over time, and there are things that require a lot of practice, but certainly it's something you could get good at. And again, there's even if some of the evidence is not quite there for some of the manual therapies that we talked about, again, it's kind of low risk and it's also low cost. So those are both two good things. And then again, there's other benefits that the patient may experience. Afferent, efferent, so just make sure you kind of understand some of those things that we talked about, the importance of, again, the nervous system and why we're doing some of these things. And again, just kind of understand the convex concave rule. I'll give some examples in our lab just to kind of help you get a better understanding of that. And that's actually something you will go over even more in therapeutic exercise. And again, understanding of indications and contraindications, just to make sure that you're providing safe treatment to the patients. And these are your objectives.